Hello, my name is Ruben Mesa, and I'm the Executive Director of the Mesa Cancer Center at UT Health San Antonio, MD Anderson. And really delighted to be involved with this patient session, along with this wonderful update meeting in hematology. My topic is going to be regarding myeloproliferative neoplasms, both the gaps and the guidelines. Here are my disclosures. So the myeloproliferative neoplasms are a group of chronic leukemias, myelofibrosis, polycythemia vera, essential thrombocythemia. They lead to an overcreation of the blood counts, and they can lead to a range of different difficulties. Now we're going to talk a little bit about how your physicians think about these diseases and how we come up with guidelines to have the diagnosis and treatment and monitoring of these diseases be relatively uniform across the United States. Now, guidelines are where we gather a group of people together. This is a bit of a facetious picture, looking a bit like something from Mad Men, where you gather a group of people together and you look at the evidence from medicine to try to come up with the best approach that can be somewhat standardized across the United States. Now, guidelines help providers and physicians kind of understand the parameters. What are the guardrails? What are the medicines that might be a consideration for a certain individual? Now, how those guidelines end up being applied, which medication, which dose, etc., that's really the art of medicine. So the guidelines are the science of medicine. How that's applied is the art of medicine. Now, let's begin by really talking about what does it mean to have an MPN. These are chronic leukemias that can affect people in a range of ways. Maybe risk of blood clots or bleeding. Maybe a drop in the blood counts. Anemia can be present in the majority of people with myelofibrosis, but less so and uncommon in P. vera or ET. There sometimes can be a drop in the platelet count. There can be enlargement of the spleen, a filter for the blood, and that can cause discomfort. There can be symptoms. Frequently, these can include fatigue, night sweats, and others that we'll discuss. There can be a risk of progression, either from earlier disease like PV or ET to myelofibrosis, or to acute leukemia. But none of this exists in a vacuum. You're an individual, and your age, the medications you're on, your other illnesses are all a factor, your baseline health. So all of this gets woven in together for us to consider how the disease is affecting you. My group has been very interested in understanding the symptoms associated with these diseases and created a series of questionnaires, the MF symptom assessment form and then the MPN symptom assessment form, to look at many of the symptoms that can affect people with the disease. These have now been validated in multiple different languages and become the standard across the world to assess these symptoms. So what sort of symptoms can be present? Well, one, there's no guarantee that you're going to have symptoms, but they can be present, and some of them are pretty common. Fatigue is the most common. It's very common at 92%, and it can be, in some individuals, severe. Insomnia, sad mood, difficulties with concentration, sometimes worse with low blood counts. And these are in decreasing order of likelihood of being present or prevalence. Early satiety, meaning filling up early when someone's eating, particularly if the spleen is enlarged. Inactivity, issues with intimacy, and this is broader. This can include issues such as erectile dysfunction, but it also can include issues of a decrease in sexual desire or other aspects, very common. Night sweats, dizziness, abdominal discomfort, bone pain, headaches, cough, weight loss. Some of these are less common, and I associate more with more progressive disease, such as weight loss and fevers that are more in patients that have myelofibrosis. If I'm monitoring patients with PV or ET for long periods of time and they start to have weight loss, and fevers, I am concerned about potential progression. Now, this approach of using questionnaires to assess symptoms both at baseline and throughout the course of the disease has become a very standardized way of looking at these issues in patients with MPNs, both in clinical trials and in practice. Now, symptoms tend to change during the course of the disease. Early on in the course of the disease, people tend to have symptoms, inflammation, maybe they've had blood clot or bleeding events that may add additional symptoms. As we start them on therapy, we hope that these symptoms improve. If there's iron deficiency or other medication-related side effects, there can be other worsening of symptoms. And as you see over time, there's a push and pull between benefits of therapy that improve symptoms, but that medication-related side effects or disease complications sometimes can worsen symptoms. So our relationship as physician and patient is kind of a continual monitoring of really where you are with the disease. Our goal is to have the disease be as invisible in your life as possible. The maximal control of symptoms that we can achieve, hopefully with a minimum related amount of medication side effects. So why so many symptoms? We think there's a variety of drivers. Some of them may be related to marked elevation in the blood counts. Some can be related to inflammation. Now, we know these diseases are driven from genetic changes, not in the genes that you're born with, but in genes that change throughout your life. The most common of these are changes in the gene called JAK2. JAK2 is an on-off switch for the creation of blood cells. And there's other genetic changes like this, such as calreticulin or MPL, that can be mutated, that drive overproduction of cells. But what we found over time is that along with this overproduction of cells, there is an increase in a variety of proteins in the blood that we call cytokines that can lead to inflammation, possibly lead to the additional scarring that develops in myelofibrosis, may cause pressure on the cells to gain additional genetic mutations. When we started studying MPN symptoms, there were some out there who wondered whether these symptoms were not related to the biology of the disease, but were related to the anxiety and uncertainty of having a chronic illness such as an MPN. What we found over time is that there's probably a component of both. It is true, as we have done additional studies, that fatigue sometimes can be worsened by underlying depression or anxiety over the uncertainty of having an uncommon disease. You know, for many of you, there's a stress. You have a disease that your friends likely have not heard of. And as you bring it up to them, there is uncertainty. You have to explain the disease. And either you explain it in such a way that sometimes your friend or loved one may think that you're going to die tomorrow. Or conversely, you might downplay the disease or symptoms because you don't want people to worry or you don't want people to treat you any differently. But all of that causes a stress. You know, if you tell someone that you have breast cancer, they have a frame of reference. They likely have had a friend or a family member, or maybe even they themselves have had the disease. They know what it's like for people to undergo chemotherapy. They clearly are both supportive and empathetic. When you have an uncommon disease like this, sometimes that support, which you deserve, sometimes is much more complex. We have learned over time, as I mentioned, that there is a lot of link with the biology of the symptoms, and that although depression and other things can be a factor, it rarely is the main driver. So, for example, fatigue has multiple biological pathways that are implicated and associated cytokines, and ways that medications, if helpful, can make a difference. Abdominal symptoms can have multiple different drivers, both from enlargement of the spleen, from prior blood clots, from other cytokines or inflammation in the intestinal symptom or in the abdomen. Constitutional symptoms, with things such as fever, chills, night sweats, weight loss, can have multiple connections to different aspects of the biology of the disease, as well as multiple ways that therapies, when helpful, can help to decrease those. Microvascular symptoms can be present, and these can be related to the blood not flowing as we would like. Discussed that blood clots can be common in MPNs. The blood clot is an extreme where the blood is no longer flowing through a blood vessel, literally like a plugged tube. Here, it's more an issue where the cells are not flowing as we would like, even in the absence of a complete obstruction. Now, as you and your provider team try to develop your treatment plan, you need to be mindful of what are the treatment goals that are present: thrombosis and bleeding, symptoms, activity, splenomegaly. Is it improving low counts? Is it improving survival? It is logical as a patient to say, boy, I want all of these things, and we would for you as well. But as we pick specific therapies typically have the ability to impact one or more of these areas. There are some of these areas where we do not yet have medicines that accomplish these. So it's always incredibly important as we pick a therapy to have a shared understanding of, is it likely to be helpful? What does success look like? How long will it take for us to have success? And if we're not successful, what do we choose next? So let's talk about the diseases. For essential thrombocythemia, many of the issues overlap with P. vera. And some of the problems occur earlier in the course of the disease, such as controlling counts. And there are symptoms that can be present more initially, such as headaches, microvascular symptoms, difficulties with concentration, and others later in the course of the disease if it moves to myelofibrosis. Progression tends to occur after time. It's not a guarantee, but after 10 years or more, and there can be risk of vascular events. As we manage ET, we have a diagnosis, we assess the risk, we develop a treatment plan, we have frontline medical treatment, which typically includes either using hydrea or pegylated interferon in individuals that need medical therapy. There are some that we can manage with aspirin alone. If the disease progresses, we treat it in a different way. If those first treatments don't work, we might consider second-line therapy, such as anagrelide, circling back to one of the others, or ruxolitinib. Now with ET, there are gaps which remain. Hydrea or interferon can be used. Which one is the best? We currently have a phase 3 study ongoing to try to answer this. How do we prevent disease progression? And JAK inhibition, which is approved in MF and PV, should we be using it in ET? Something under evaluation. There are many drugs that are under investigation. In ET, there is ropegylated interferon in a trial led by Dr. Verstovchik and I. There is IMG 7289, a new drug that is an LSD1 inhibitor. With PV, there are multiple drugs that are being developed, including the hepcidin agonist, PTG300, which is trying to make individuals phlebotomy independent, and other drugs in development as well. Now, what about polycythemia vera? The story is very similar to that of ET with slightly different drugs. Here, the question is, again, what is the best therapy? Is it interferon, long-acting interferon, or hydroxyurea? And ropegylated interferon may become available in PV sometime later this year, at the beginning of next year. Now, we've done studies comparing interferon and hydrea, and we did an analysis to try to get a sense of the impact on symptoms. Interesting thing that we found with this was that one, both drugs can have an impact on symptoms. Two, interferon sometimes can have its own disease-associated side effects. Three, if you have a lot of symptoms, being on therapy clearly improves them. If you come into therapy with no symptoms, you likely are going to have a net little bit of an increase in symptoms from the side effect of the medications. So people say, well, why are we using the medicines? Well, we're using the medicines both to decrease the likelihood of blood clots and bleeding as well as improve symptoms. So we're learning more and more about how to triage the importance of symptoms in choosing these therapies. Now, myelofibrosis. In myelofibrosis, the disease is more serious. It is a greater burden, and we consider bone marrow transplantation earlier in the course of the disease, particularly with individuals with higher risk disease. Here we have splenomegaly, enlargement of the spleen. We have cytopenias. Frontline medical therapy has included ruxolitinib or fedratinib. If transplant is not selected initially, we may consider it as a backup option or second-line treatment or treatment toward acute leukemia. There are new drugs in development, 2 additional JAK inhibitors, which may become approved in the near future. Pacritinib, which is active for particularly individuals that have low blood counts, but also help to improve spleen and symptoms. Momelotinib, which is particularly helpful for individuals with anemia that may have complementary areas of benefit. There are many new drugs in development for myelofibrosis, either alone or in combination with ruxolitinib. The good news is that some of these therapies, if beneficial, may then be extended to also impact people with earlier disease, such as PVERA or ET. Just highlighting a couple of these include imetelstat, which is currently in a phase 3 study for myelofibrosis. The apoptosis agents such as navitoclax, alone or in combination with ruxolitinib, as well as the MDM2 inhibitor from Kartos, and epigenetic modifiers such as the BET inhibitor from Constellation or the LSD1 inhibitor from Imago. Now, therapies are improving survival, and we are learning more about this. I think that it's been shown that patients receiving ruxolitinib and having a response, potentially fedratinib, momelotinib, and imetelstat all might have benefits in terms of survival. I think this is beneficial, and it shows us our therapies are making an impact. 2, we're seeing evolution from possibly moving from just using one drug at the time of diagnosis to potentially 2, with recent data suggesting that the addition of second drugs may be beneficial upfront. This is currently being validated in current phase 3 clinical trials. So newly diagnosed patients with MF who have not yet received a JAK inhibitor, a combination may be a consideration. Should we be using combinations in all patients? All of this is very much of an evolving question. Final takeaway, what about adding 2 drugs together? I think we still are uncertain. If an individual is on a JAK inhibitor and they're having a suboptimal response, do we add a second drug or do we switch to a second drug altogether? Many different studies are ongoing to try to answer this question. The takeaway, I think, should be hope. Many drugs being developed, many that are having an increase in the activity against the disease. We're learning more about how these drugs are impacting other markers of the disease, such as scarring and survival. Finally, some important complementary approaches are out there. Yoga, activity, nutrition, and cognitive therapy that we're trying to better understand and weave in along with medical therapy to help you along your MPN journey. We've seen that yoga can be beneficial, helping both with mood, sleep, and inflammation, and working on cognitive interventions to help deal with some of the anxiety along with better approaches with meditation, and even potentially with nutrition and inflammation. Finally, many new trials ongoing to try to understand this complementary approach well. So I'll conclude by saying your diseases are important. We care about you. There's multiple new therapies in development, alone or in combination, as well as increasing information of how we might use some complementary approaches to help you along the way in your journey. So with that, I would very much like to thank my group. We have many investigators across many institutions working together as the MPN Quality of Life Study Group to help you in your MPN journey. Thank you.